this a lot in people that either squat or do lunges or do anything like that. So biomechanically, if they go up and down, especially if they have a load on them, if they have a bar, if they're holding weights, something like that, it's a really good way to crash them because they can't handle that up and down. Their vestibular system gets all out of whack. Their biomechanics get all out of whack. They get dizzy. They start to get nauseous. People puke. So that kind of thing. So just, I wanted to show you guys that video because Jerome was talking about that a lot last week and he didn't have like a visual for it. I thought it was kind of important. So anyways, does everybody here know Bryce? Cool. Bryce is our research coordinator. He's one of our officers in club. He's really passionate about this stuff. We were talking about cranial nerves one day in class, and he's like, "Yeah, I found this book. I think I'm going to read the entire thing." I was like, "Okay." So he came to me the other day, and he was like, "So I finished it." And we'd talk back and forth in class. We kind of disrupt each other and distract each other, but he went ahead and he just took it upon himself. He's like, "I'm gonna go learn some stuff," and he's super knowledgeable about what he's about to be talking about, which is cranial nerves today. So I was like, "Dude, come talk about it. Come share the wealth and let us know what you got." So that's what he's about to do. So Bryce, take it away, man.
All right, cool. First off, I'm gonna try 3. I'm sure a lot of this stuff today, like reviewing the cranial nerves, is you guys have already done it before in class or something, but it's kind of one of those things where it's good to review it because you should be able to quickly list it off, especially if you want to be a functional neurologist. You know, cranial nerves are pretty important. We talked about the reticular formation in the brainstem, and you know, what is the reticular formation? It's a lot of nuclei. A lot of those nuclei are coming from your cranial nerves. It's where they come into. Anyways, we'll get there.
Maybe your flipper.
Jason added some extra slides in the PowerPoint that I gave him today. We'll see what's in there. Okay, so does anyone have any good mnemonics on how they remember cranial nerves? The one I like is, on occasion, our trusty truck acts funny, very good vehicle anyhow. There's some other ones, and there's probably some more inappropriate ones that you guys know or have memorized. But whatever it works, or however it works, how many cranial nerves are there? 24, so 12 pair, right? 12 on each side. Oh, by the way, I'm trying to fly through this as fast as I can. I don't want to spend too much time on the basic stuff. So if you don't know the answers, spit it out, and we'll go through it quick. We got several slides. So there's 12 cranial nerves. So on occasion, our trusty truck acts funny. Very good vehicle anyhow. My handwriting's really bad, guys. So whenever you're just looking at a picture on the brain, there's some easy ones that stand out. You know, what's this big? Hey, go back one slide so they quiz them. What's that big one that crosses over right here? Olfactory, yeah. I mean, optic right here is crossing. Olfactory has the bulbs up top. What's this big one right here? Trigeminal, right. So from there, you can kind of, you know that's 2, 1, 2, you know that's 5, so you can just kind of number them out from there if you have a picture. Actually, it's pretty easy. Move on to the next one. Okay, there's different ways you can group the cranial nerves. The one you hear us talk about a lot in Neuro Club is the 2-2-4-4. So like the first 2 neurons are kind of like before they insert the brain kind of before the midbrain. The second 2 come in at the midbrain. The next 4 are going to be coming in the pons, and then the last 4 coming at the medulla level. If you go to the next page, you can see how where these come in, their nuclei are kind of all over the place. You can see why they call it a reticular formation, because it kind of forms a web. It looks like a web. Does that make sense? And then also in this picture, you can see the different levels that they come in. Now, why this is important for us as neurologists is because when it comes to doing some therapy, first off, we're about to talk about how you would assess each one. But it also comes into play because if one of them is weak and you know the other cranial nerves that come into those same areas in the reticular formation, you can find alternate pathways to go in and try to strengthen that nerve. Okay? Another picture, the next picture on here, go ahead. It's very similar, but it also shows, so here's a cross-sectional cut so you can see what part of the spinal cord these axons are traveling. And then over here is kind of that same thing, but it has it also in the different levels of the spinal cord. Can everybody see a TV or something?
Actually, move more a little bit.
Yeah. Okay, so even though on that previous picture that it's called a reticular formation and it looks a lot like a web, it looks really jumbled up, seems confusing, there is a lot of order to it also.
Is that better?
Yeah, that's good. Obviously, you guys know that there's different tracks in the spinal column, so there's order to that. But then I really like this picture because it breaks it down from medial out to lateral and shows you how in these different columns, there's different cranial nerves that come in and travel up together, basically. So if you look right here in the midline, you'll see 3, 4, 6, and 11. What does it have? What do those have to do with?
That should be 12.
Or 12. Is that 12? Yeah, 12. I don't know my Roman numerals here. So what's 3, 4, and 6?
Eyes.
3, 4, and 6 are eyes, right? And then 11? Okay. I mean 12, I'm sorry. That's 12. Spinal accessory, right? Does anyone know what spinal accessory does? Yeah. It's back, SCM and upper tract. So head movement. So there shows you right there an example of how eye movements and different eye movements are directly related to where your head is positioned in space.
What are those called? These columns? Huh? Yeah, homologous. Homologous, aka they're born at the same time. So those, if every one of these, you kind of develop in the womb. You develop medial lateral, right? So you develop here, and then you develop here, and then you develop here. So these are born at the same time, so they can fire together, right? So that's what he's talking about. So eyes can play a lot into the spine. We've talked about those too. So when you think about a homologous column, think about those. And this picture is really good because if we adjust somebody, what side, okay, from the cerebellum up into the brainstem, what side pons is it going to go to? Same side or opposite side? Same. What about midbrain? It's going to go oppo midbrain, opposite midbrain. So if I adjust somebody on the left, you can look at these and say, okay, these pons in the medulla, I'm going to affect on the same side. So if somebody has like a cranial nerve lesion, I can maybe boost it through an adjustment, right? That's pretty sweet because nobody else is going to do that. If you go to like an eye doctor or something like that and people have like diplopia or double vision and people are like, yeah, I wear glasses, but I feel like that's not what's going on. One eye maybe like not yoked with the other one. You can boost one side, stuff like that. Vestibular stuff, you can go into same side pons medulla, you can go to the opposite side cranial nerves for the midbrain with an adjustment. Freaking sweet. And like I said, no other healthcare professional is doing that. Not through like nervous stimulation. So pretty cool.
Okay, yeah, let's go on. Okay, so we talked about the order. If you have your mnemonic down, it's pretty easy to go through those. These are different. So let's go through each one real quick. Olfactory, what comes to your mind when you think of olfactory nerve? Smell, right? Is that going to be, what kind of nerve, what kind of axon is that going to be? Is it going to be sensory or motor? Okay, is it going to be somatic or visceral? Visceral is like the special senses, right? Okay, optic is also special sensory. It's going to be vision, so the ability to see. If you go one more slide, we'll probably come back to this.
All right.
So real quick, somatic sensory. They're sensory, so it's coming from your receptors for pain, temperature, mechanical stimuli, different types of movement, proprioception. I think you guys got that down. The visceral sensory, it's coming from blood vessels or digestive tract. It also includes your special senses, right? Mm-hmm. Then you got your visceral motor and somatic motor, which is like skeletal muscle. So go on to the next slide. So if you look at the motor types, what are the different, let's just go through and group them as motors. You have all your eye movements, right, which is 3, 4, and 6. You got your tongue muscles, and then you have your facial expression muscles and your neck movements. Take 2 slides back, Jason. Okay. Let's run through each of these real quick. This is going to be, I want you guys to shout it out, okay? Because I don't want to sit here and lecture here. But we talked about optic. What about oculomotor? Moving eyes. So we talked about 3, 4, and 6. What is 4? What specific eye muscle does 4 go to?
Lateral rectum.
Right.
Superior oblique.
Superior oblique. Lateral rectus is 6, also called abducens because it's abducting the eyes. Okay? Makes sense.
So for chiropractors, spinal accessory, what two main muscles do spinal accessory go to?
Trap.
Say it again? Trap and SEM, right. Okay, so if it's my left side, left cranial nerve, right? Is it going to go to, is it left or right SEM? Same side. What way, or what does the SEM do? In the opposite way. So that's the only thing I was going to mention. If you're testing, if you're muscle testing an SEM and you're muscle testing the left SEM, it's right rotation because it's going to do this, right? So if you're testing it, don't do like, well, they couldn't shrug with their trap on the left, so I went to the SEM, but the SEM's on the wrong side because it's the left. That's a dodo move. And we try to not do dodo moves in this club, right? So make sure that it's an SEM. You're going to go the opposite way, and that's a left SEM with right rotation. Because a lot of that, when we adjust, we do stuff like that, right? So if you adjust, and we'll probably do that at the end when he's done, if we do cervical manipulation, it's like if you go do a thumb contact, you can grab the SEM and you can fast stretch it as you adjust. Or you can grab a scalene, you can do stuff like that. So we'll talk about that. But just something to consider as we apply adjusting into this.
Just as a quick raise of hands to save time or to move on if we don't need to do this, who feels like they have a pretty good concept of what each cranial nerve does, like the function? Most people in the room. Okay, so now what I want to do next really is to go through and talk about how for each one of those, how would you do an assessment on it? So like as a chiropractor, how would you do a quick assessment? We're not going to talk about, you know, if something's not right, how would you further assess it? But just how would you do a quick evaluation and check to make sure that it's functioning properly? Okay, cool. So go on to the next slide. Keep going. One more time.
I think it was,
And
oh wait.
Go back one. So here's an example like of why I'm not going to spend too much time talking about what all can go wrong, because just looking at the abducens nerve, you know, here's 4 different scenarios of what you might see when you're checking that nerve, which is 4 completely different things, which would all require, you know, further assessments to verify. So let's stick to the basics, and then if we want to go back and add more detail, we can spend time doing that.
Can I say one really quick thing about eyes? A lot of you guys are going to pursue this, so I want you guys to get this concept, okay? Because I feel like you guys are a group of people that want to know more instead of just dancing around like basic stuff. So if I've got an eye, let's say it's my left eye, and it drifts inward, is the inward muscle broken or the outward muscle broken? Outward muscle, right? If me and Bryce are tug-of-warring that shirt right there, and I go weak and I let go, the flag is going to go to him, right? So don't think if the eye's in, don't sit there and be like, oh, what brings the eye in? And then be like, that's that muscle, or that's that nerve, right? You want to figure out what messed up to bring the eye in, right? So if it's an abducens palsy, a cranial nerve 6 palsy, and you can't have that tug of war, that pull from the outside, you're going to see that eye go in. So just think about that. And then from the rest, you can figure it out. But that's just a concept that you guys need to get. Next.
Yep. Okay, let's go and go to the next slide. So olfactory, cranial nerve 1. How would you test that? I kind of gave it away here. But it's first smell, right? So you want to test someone's smell. Anyone give me an example of how you would test to see if someone can smell something? So would you have them close their eyes also? So take out all the other senses, close their eyes, and do one nostril at a time. And you can hold up, I mean, the way I've heard it say is essential oils work really well. But if you don't want to buy essential oils, you can have some coffee grinds or some common smells, you know. There's 2 questions you want to ask them when you're having them smell you. So you're going to have them close their eyes, close one nostril, and then you're going to slowly raise it up. And you ask them, what would you ask them? Do you smell anything? And then, what do you smell? Okay? What's the difference? What are you checking there? So, what if they... Right. And where would that be part of the brain? That's parietal lobe?
For what?
What you're smelling, the awareness of what you're smelling.
Where's it going? Oh, Spencer, what do you think?
Orbital frontal.
There you go.
Orbital frontal. Okay.
which is really good for PTSD patients too, because that's where a lot of the PTSD lesions are. Where are my sport chiros at? Or future sport chiros? Anybody? Okay, cool, fair enough. So if you guys have an athlete come in, let's say he bangs his head, or let's say they are pretty fragile, if you go with a really strong smell, it actually activates cranial nerve. We're going to hit the trigeminal too, so 5, and it's going to give them a really strong headache. So if you guys have ever had a really strong smell that immediately just lights you up and you get a headache because you get super sensitive, that's 5, and that's, I mean, you kind of want to stay away from stuff like that. So if you're in a clinic with really fragile patients like some of us are, you don't even want to wear, like, you want to wear deodorant, but you want to stay away from like perfume or cologne or that stuff, because you're going to get really close to a patient, right? If you're going to be up and personal with them, and you're going to actually make them worse when you're trying to make them better. And so you're going to be sitting there and they're like, well, yeah, I have a headache today. I don't really know why. I was feeling good yesterday. And it's just like, you don't want to do anything to like kind of screw up your therapy. So just a thought.
And there's a couple papers in here, but just an interesting side note, there's a study done that showed patients with autonomic failure, one of the things that tanks is their olfactory function. So, for example, you know, if you know these things and you know that connection there, if you have suspect that one of your patients is in autonomic failure, test their olfaction. You know, give them a cranial nerve exam. Okay, before we move to the next slide.
Yeah, I got a question.
Oh, sorry, Parker.
Are there any smells that won't hurt them that would help in that like regard?
That's a good question. We normally stay with like really like, what are some of the, I guess,
lavender?
Yeah, that, do you have some?
Yeah.
So lavender's a good one, eucalyptus is a good one, citrus is a good one. It's like sage?
Mm-hmm.
It's a lot of things that, and yeah, Layla would be good to talk to about that for all the massage therapists and people that do like aromatherapy and stuff like that. They'd be the ones to ask, because if you think about the aromatherapy smells are the ones that calm you down.
Yeah.
They're not the ones that like wake you up really fast. So
another interesting note: this is the only cranial nerve that bypasses the thalamus. So I think that's super interesting, and I think that's the reason why a lot of people use certain smells with like study tools, study aids. You use a certain olfactory, certain smell while you're studying, and then you use that same smell to bring out those same, I don't know, you're bypassing that conscious thalamic control.
let's say you got 6 classes by 6 different oils. If you're going to study fizz, have a fizz oil. If you're going to study micro, have a micro oil. And then you smell it right before the class, and that's classical conditioning. You're just whoop, you light everything up. Same thing you were studying, you get way better grades on your test. So.
So before so cranial nerve 2. I threw up a couple of things here, but pretty much vision, what are those posters called? Yeah.
What is it, Tyler? Stellan? Oh, okay.
So what would a patient might complain of if they came in and their optic nerve wasn't functioning properly? Can't see, blurry vision, things like that. Another thing, since we're on eyes here, you go to oculomotor nerve. One thing the oculomotor nerve is responsible for is the parasympathetic constriction of the pupils. So you can also want to do your pupillary light reflex to make sure that's working properly. Then also for the eyes, you can do a simple tracking, having follow your finger in all the cardinal planes. And when you're doing that, you're checking, just like we did before, checking to make sure that those eyes are able to track all the way over. And just like Jason said, if the eye's not able to track all the way in one direction, then that would be the weakness in that muscle that's supposed to be pulling it in that direction. Makes sense? Pretty simple. Let's move on to the next one. Also, another thing, when you're doing the eye exam, you could also be looking for, since you're checking the oblique lines also, and you start seeing a nystagmus, that gives you other clinical signs that there could be something going on in the cerebellum. Cool?
Here, stay here, keep going.
Real quick, I don't know who's planning on working with pediatrics, but there's also good tips here for each one of these cranial nerves is how you might assess an infant on these same things.
Wow.
So, just to point out a couple of those, you can use bright objects or something to get them to track with your eyes. But having people, familiar smells, obviously, shine the light. It's going to be better when we get to trigeminal. So the next one I want to talk about is the trigeminal, big nerve number 5. You guys know that it's sensory on the face. So how would you test that?
Touch it.
Do a cotton swab, or do something light touch to make sure they can feel it, and it's the same, equal on both sides. A reflex that you can test with infants on the trigeminal nerve is the rooting reflex. So giving them that touch there, and it should make them go to that side.
You can use it therapeutically too. It's another way to go into the pons, or it's another way to go in a little bit higher up in the midbrain if you go into V1. So if you guys do want to go in, going back to that first picture where you saw all those nuclei and all that kind of stuff, and their autonomics are kind of messed up, if their eyes are kind of messed up and you think it's affecting their spine, their paraspinal muscles, to where their adjustments aren't holding, it's a good way to go in. So what we would normally do, we normally do the same side pons. So we would normally do, we would do an E-stem, but you can do vibration on the same side you would adjust them on. So you could either have it on a V2 or a V3 on their tongue, and then you could adjust them. Let's say if that was left and left, you could adjust them on the left side, or you could try to spin them to the left, and it's just to boost it a little bit. So that's without getting too complicated of a patient. But like the majority of people, that's probably how it would swing.
Okay, we talked about 6 was the lateral rectus. That goes along with the eye movements also. Now when you get to 7, what is 7? Facial nerve, what are we looking at here? Facial movements, right? So what could you do to assess, a 4-year-old kid, assess their facial nerve?
Raise their eyebrows.
Yeah, get them to make funny faces at you, things like that. For adults, you don't want to tell them to make funny faces at you. Wrinkle up your forehead, look up at the ceiling, close your eyes tight and don't open them. Just have them do a couple different facial movements and make sure everything's symmetric and working properly. 7, with the 8, so okay, when you're doing your eye exam and you start seeing a nystagmus, what cranial nerve are you thinking now?
7? What'd you say?
A nystagmus, when you're doing an eye exam, you're getting them to track the finger and you start seeing a nystagmus, saccades. You would start thinking maybe vestibular. Something could be going on vestibular, right? Does that make sense? Okay. So a lot of these exams. Okay, let's move on. Yep. Next page.
I think you're talking about 8 for vestibular.
Yeah.
Are you asking what cranial nerve?
Yeah. Okay. That's what I was looking at for there. So also that's another thing. When you're doing your eye exam, you're also can be testing your vestibular, because if someone's having a vestibular problems, you're probably going to see a little bit of a nystagmus or something going on when you're looking at their eyes. That's what I was getting at there.
Cool.
So just real quick, this is from a pretty good book, and it's just talking about a rapid sequential screening for these cranial nerves. Some of this is uploaded to the web page, but it's basically just like how can you go through asking questions and assess all the cranial nerve function in less than 2 or 3 minutes. Okay, so since I'm a neuro guy, this stuff's easier for me. Just talk about research. And I just want to throw out some gems of how going through each one of these, some of these cranial nerves, how they're used in different types of therapy. For example, I already mentioned this one, how odor identification, it pretty much tanks in patients with autonomic failure. So a good way to screen for autonomic failure is test their olfactory system. Cool? Here's a really good one for chiropractors. They found a connection with oculomotor dysfunction and idiopathic scoliosis, especially in younger patients. So you've got younger patients who are continually subluxated, and you keep adjusting them over and over, and they're not getting better. Have you checked their eye movements? Have you checked to see if they've got something going on there? Okay, this is talking about the trigeminal nerve stimulation and the treatment for epilepsy. And all these studies are posted on the website. They're pretty interesting reads, pretty specific. And then there's the same thing, vagus nerve stimulation with epilepsy. Go on here. And then from there, this is more experimental. There's not really much hard science behind this, but another thing with focus and with studying using different rapid eye movements can help activate certain parts of your brain if you're trying to boost up function in certain parts of your brain. Does anyone have any questions about the cranial nerves that I can answer? I know that was really fast, and I hope y'all got anything out of that. No questions? You have anything you want to say, Jason?
Yeah, let's talk about these really quick. So we were sitting there this morning and we were trying to make sure we had these right because some of these books were kind of confusing on it, but these are really important to know. So if your eyes look down and in, what muscle is it? It doesn't matter which eye, they're both going down and in. Huh? Not superior rectus, superior oblique. If you look up and in, what muscle is it? Inferior oblique. What nerve is in and down? Down and in? 4. If you go up and in, what nerve is it?
3.
So if you guys are, alright, I'll just have a pretend patient in here. As you guys are doing if you guys do an H, you say like, follow my fingers, right? So if you have like your thumb or you have a pen and you say, follow this. When you go down and in, if you go to the midline, you go down, what nerve are you checking?
4.
Where in the brainstem is it? Pons. So you're like, okay, cool, pons is intact. Next. You guys see how you guys can kind of apply that? If I take them out and to their left, what muscle is it? Lateral rectus, and what nerve? 6. So I'm like, okay, cool. And then where's the abducens at? 2, 4. No, it's still pons. Bottom of the pons. So it's like right where the pons and medulla kind of, like those two bumps meet. So you go, okay, cool. That part of the brain's intact, right? So you're literally going around, and in your head, it's just automatic going, I want to know how their pons is doing. Down, it's good. Their eyes went in, right? And they come out. Okay, that part's cool. Now I'm going to check oculomotor. So I can go up and out, right? Because all that's oculomotor. If I go up, straight up, what muscle is it? Okay, if I go up and out, what muscle is it? It's still superior rectus. That's a tricky one. Doesn't really make a whole lot of sense, but basically where the eyes are, their origin, or actually where they're inserted on the eye, if they go up and if they go up and out, it's the same thing. Superior rectus, okay? So that's a way to kind of check those cranial nerves. Another way to do it, so we were talking about saccade. So what's a saccade? Shout it out. Rapid eye movement, right? So we said that it was a frontal lobe. That frontal lobe is going to fire down to the... Let's draw this out. Actually, this is really good. We'll talk about that in a second.
Hey, okay, so just a way that I remember that, of what direction each muscle's pulling the eye. If you remember that the eyeballs are kind of facing out when they come out of the brain, that makes sense. The superior rectus is going to take your eyeball up and out. Okay? And then the obliques are the ones that turn it either extort or intort it back into the midline. Cool? Can you draw something?
Yeah, might as well. Alright, so we're going to talk about a saccade because I told you guys it's a frontal lobe thing, right? So I'm going to give you guys the next step in that to basically show you guys how that works. So let's say alright, and then we'll say alright, what are these things?
Cerebellum.
Okay, what's up here? Is your cortex. We'll say left. We'll say right. Okay, what's right here?
Midbrain.
Say it again?
Midbrain.
Yeah, I should have done that up here. So we'll say midbrain, pons, medulla. Okay? Your cortex, let's say something's really, really cool over here. If you're a guy, Jennifer Aniston just walked up.
Yeah.
Or if you're a girl, I don't hate it. Alright. Does anybody know what would be about right here? And if you're looking straight ahead, right? You're looking right here. But you see something out of the corner of your eye. What would draw you to something really, really cool over on the left? What you got, Todd? Superior colliculus, right here. So if you got something really, really cool on the left, your right superior colliculus in the midbrain is going to go, you got something going on over there I think you should take a look at. And you go, cool. So this cortex, let's say the right, because we want a saccade to the left. So we know that right frontal is the left saccade, right? You're going to fire down to the superior colliculus right here. And the superior colliculus is going to come over here to this thing called the PPRF. That's called a burst neuron. So that's the neuron that's basically going to go to that the abducens nerve. All right, actually, let me do it. So there's a PPRF. Right above that is the nucleus for cranial nerve 6. So this is your burst neuron. It's going to go in here, and it's going to fire cranial nerve 6. So like, let's say if this is your eye right here. Cranial nerve 6 goes to the abducens, or the lateral rectus, excuse me, right? So you wanted to get over there. Your burst neuron is going to fire to cranial nerve 6. Cranial nerve 6 is going to fire the lateral rectus. So we've got this thing right here, and this is for you advanced people, called an omnipause neuron. It's going to always fire. If you're looking at something, it just says, stay where you are, stay where you are, stay where you are, stay where you are. As soon as that thing stops, your eyes move, and then once your eyes move, it starts again and goes, stay where you are, stay where you are, stay where you are, stay where you are. There's a part in your cerebellum, and there's multiple parts to this, but there's a part in your cerebellum that once it goes where you want it to be, your cerebellum goes, is this where we want to be? Yes, this is where we want to be. Okay, we're good, everybody. It's kind of like your traffic controller, right? So it compares it. It goes, should this be where we are? And it goes, yes. Okay, don't move. So that's your integrator. So your cerebellum, so now we've got a right cortex, left cerebellum. So do you see how those kind of work together? But in the meantime, you've got all this stuff going on in the pons, the opposite side pons. So you've got the omnipons, you've got the PPRF, you've got another middle, we won't even go into that. So basically, all I was trying to get by doing this is what's a really, really easy way to assess somebody's midbrain is just say, hey, look left, boom. Hey, look right, boom. Because if they can saccade in either direction, they've got to have that, right? If they don't have a good integration, or if they don't have a good omnipons, you're going to see a saccade, and then it's just going to drift back because they can't hold it. They don't know where they are.
So this is for people whose like eyes constantly jump around. Because have you ever been into a conversation with somebody and they just can't? They're like jumping.
Let's talk about ADD.
Okay.
So this is your superior colliculus. What inhibits your superior colliculus? And there's a reason why it's in the midbrain, by the way. Guess what else is in the midbrain that's super, super important? Basal ganglia. It's right here. And it fires down to inhibit that. So what is your job of the superior colliculus? Its job is to find cool shit around that says, hey, look, just look. And it has a map of itself, and it has a map of everything around you, so you know where you are. So they call ADD what? Attention deficit, people that have not enough attention. When really it's the opposite. This basal ganglion isn't like telling that superior colliculus to calm down. So everything you see is like bam, 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 bam. And you have input from the auditory cortex, so you can basically saccade to a sound. If something scares you, you're like, boo, right? So you've got all these things. If something comes up in your vision and you're like, oh, cool, and you're like, boom, oh, it's just Paul. And then like, oh, something like, oh, it's just Matt. And then, but like, you're always like, what is it? What is it? What is it? If you've got a good brain, you don't do that, right? You're like, I'm cool studying. Because that's our big thing. Like, we sit down and we're like, I'm supposed to read about micro for the next 2 hours. And like, any little thing that happens, you're like, what is it? What is it? What is it? What is it? You know what I mean? So you want the basal ganglia to simmer that down. There's your ADD right there. If you fix this, guess what gets better? Guess what you can do to an adjustment? Adjust them on that side. You know what I mean? That's something that would help them.
How do you tell which side is the...
By checking cranial nerves.
Okay. Basically.
Yeah. What cranial nerves are in the midbrain? So which ones are in the midbrain? Let's put it that way.
3.
3 and... So what's 3? Oculomotor. Guess what you can do with ADD kids? Get them to gaze fixate. As a physical therapy, and it gets better. What's 4? Yeah, trochlear. So a lot of eye stuff. So you can build up that part of the brain, and guess what goes away? And their parents will love you for it. You can also do basal ganglionic stuff. So you can do, I mean, that's opened up a whole, we need to spend a whole day on basal ganglion, so we won't go there. But a lot of that is trying to gate. You see basal ganglionic people, what do? If they're hyperactive, they tick. Or if it's broken, it's the other way around, and it's the indirect pathway. What do? They're like super chill, and they don't do anything. So there's a difference between ADD and ADHD. So Parkinson's, hypokinetic, right? So that's cool. So are you guys starting to see that you guys can play around with stuff like that? There's a lot of times where people are like, oh, they just got ADD, and it's like not localized. You know, they don't try to find a localized lesion. We're just going to try to give you some neurotransmitter and a drug to see if we can change that. So if we try to boost your brain by a neurotransmitter, let's say the left side's good to go. This is up running at 100%. You give them a drug to boost those neurotransmitters because this one's at 80%. Guess what? Now this one's at 100. This one's firing at 120. This one crashes, and you just made them worse. So if they're on their drug, they're like good, and all of a sudden they crash for 12 hours as soon as it wears off. I don't know how that stuff works. I'm just thinking out loud. All I know is you can boost both sides because drugs aren't going to affect one side of the brain or the other, right? Drugs are going to do both sides. Both sides up, both sides down. So that's cool as a chiropractor because we can go in and say the left side's good. We don't need a drug for the left side, but we can adjust them on the left side, or we can adjust them on the right to hit the left brain. Does that make sense? That's what we have that medical doctors can't do, especially in neurology. So in the system that controls everything, an adjustment's way, way better than some of these medications that just go up and throw everything up at 150% or down to 20%, stuff like that. It's cool stuff to think about.
Without the action of the basal ganglia or these omnipause neurons that are letting you fixate, it would almost be like reflexive. That anytime you saw something move in your visual field, your eyes would instantly saccade to it, so you could see what it was. The basal ganglia and the omnipause neurons allow you to, overcome that and fixate on something.
Crazy stuff. You guys want to adjust a little bit? Yeah. Do anybody have any questions before we go?